All right, I'm going to hand it over to my colleague here, who can introduce himself.
Hi, everyone. I'm Arash Rahmani, an international medical graduate, and I'm very happy to be here. Thanks for the invitation, Dr. Peter, and it's a pleasure to be here. First, I will, this one?
If you hit that, that should go to the next slide. Oh, or just look in the middle. There you go. That's right. There you go. You want to get rid of the pictures? Is that distracting to you? You can hit. Just
Yep, you can hit that one.
There you go. Just move that out of the way. There you go. Yep.
Just as I mentioned, I graduated medical school in Iran, and then I went to Canada. I have been working as a postdoc in neuromodulation and neuroimaging in SUD for past year. That is one facet of my work. We are interested in precision neuromodulation and how we can engage, for example, specific circuits in the brain specifically from frontopolar to amygdala, and see how it affects craving. And like many other experiments in the pilot study, we ourselves were getting the stimulation. And another facet that we have been working with MDTA team, Mark Thomas and Hamed, my supervisor, and Ben and Jim, was trying to do community engagement research in neuroscience. You know, it has been there in medicine for so long time, but neuroscience, because it was considered something complicated, it may be one reason was that the researchers were not open to communicate about neuroscience research and engaging community in their research. So, during these talks, we found we are looking to have input of the society and community members about what are their actual needs, that we can also go after that and do the research. After this introduction about myself, let's start the main topic. You see here two different brains. The upper one is for a normal person, 63-year-old, and the lower one is for a person with, if I'm right, Wernicke-Korsakoff syndrome. And just for simplicity, I try to highlight the areas that you see the devastating effects of alcohol. You see the ventricles are enlarged. You see gray matter is shrink, and also the sulcuses are deepened. And just a quick question: does anyone, for example, have any ideas about neurotoxic mechanisms of alcohol that lead to these neuroanatomical changes that we are seeing here?
So what happens
Yes.
in Wernicke's?
Yeah, when we drink alcohol, what are the cellular or molecular changes that lead to this, significant?
Could you say that again? I'm sorry, I didn't understand.
My question is, what are the mechanisms behind
Yeah,
this damage to the brain? For example, one, I can help by increasing reactive oxygen species. But
okay.
there are other factors as well which are recently being studied. So if no suggestions, okay, let's move on. And alcohol, just a brief here in the room, all people are experts, is the most widely used psychoactive and is the cause of death for 3.3 million annually worldwide. And from the beginning, it's helpful to consider alcohol as a neurotoxin, which acts both directly by itself and indirectly through damages, for example, neuroinflammation, liver disease, and malnutrition, and specifically thiamine deficiency. So I was telling Dr. Peter, in literature, there are a wide range of mechanisms proposed, but here I tried to just keep the depth in an appropriate level. The main ones is oxidative stress and mitochondrial dysfunction, excitotoxicity, and neuroinflammation. And these mechanisms have overlaps as well. And in the middle of one pathway, you see, for example, another factor playing a role. So let's begin with the oxidative stress. These are the everyday factors that we are dealing with. I mean, chemicals, radiation, nanoparticles, and air pollution. And what do these things do to our body can be traced to at the cellular level. They will lead to lipid peroxidation, protein oxidation, and damaged DNA and apoptosis. In simple words, they will destroy the building bricks and blocks of our cells in our body. So in CNS, they will cause neuronal death and damage. And these are the basic mechanisms behind that neurotoxicity that we are seeing with alcohol. To delve further into it, we here see common substance uses and their pathway in which reactive oxygen species are playing a role. TLR4 is toll-like receptor 4 is an immune receptor. And all of these drugs, as I mentioned, we can consider them toxins. And there are one theory has been proposed and considering drugs xenobiotic. I mean, there are foreign agents and our body consider them as foreign agents and react to them as if they are foreign molecules. So the immune system initiated. And by activating this receptor, NFK beta, which is transcription protein will be activated, and it will go and increase the transcription of pro-inflammatory cytokines. And here, the neuroinflammation, you see the relationship between oxidative stress and inflammation, and it is like a malicious cycle. Then they again will go and by disrupting the mitochondria structure and function, increase the oxidative stress. So this will repeat itself. And also those pro-inflammatory cytokines, by activating several enzymes, increase the oxidative stress. So, and
one question there. Did you have DA, I assume is dopamine?
yes.
So suggesting that dopamine also leads to oxidative stress?
Exactly. Through different mechanisms. One is self-oxidation, the other one by being metabolized by MAOB. All of them result in reactive oxygen species.
So presumably anything that would increase dopamine could
Exactly.
lead to this oxidative stress.
Exactly. And that is when we have that, I mean, that's the balance between oxidative stress and antioxidant system you have in the body. When you use substance frequently and in high amount, that balance will be shifted to, in favor of oxidative stress and the damage downward.
Okay.
So this was one. And again, that's immune receptor activation that this is, I think, one of the core feature of substance use. I myself wasn't aware of, that they will go and activate our immune system directly. And by activating that, a downstream pathway will be activated, which is increase in transcription of pro-inflammatory cytokines and decrease in anti-inflammatory cytokines. And in further slides, I will show that these cytokines can also lead to neuroplasticity, and they will go and affect the function of channels of, for example, for neurotransmitter channels. So this is bi-directional interaction between immune system and our neurons and neural pathways. And you see in the down.
But this is
part-
not specific to alcohol,
No.
right?
No.
To be clear, so far, these mechanisms you're talking about are not alcohol specific.
No.
Gotcha.
So that was oxidative stress, now neuroinflammation. The slide is specific for methamphetamine, but the next slides are for alcohol, but the mechanism also the same. Because, for example, as Dr. Ham, I guess,
Dr. Schultz.
Dr. Schultz asked, for example, alcohol can cause dopamine release,
Mhm.
and then from here it will be the same, the pathway. And the same mechanisms. I think it was accepted that substance use cause peripheral inflammation, but by those mechanisms that I mentioned, which activate microglia, we have that additional CNS inflammation as well. Besides to that, by disrupting the blood-brain barrier, those peripheral inflammation and inflammatory cytokines can move toward the CNS and cause damage as well. So to zoom in the process, this is the peripheral side. We know in addiction medicine, there are a lot of inflammation going on in the periphery that can cross blood-brain barrier. So, but in the brain, alcohol has different mechanisms. The one we discussed that was increasing in ROS, in reactive oxygen species, and itself, it can cause neuronal necrosis. So, and that damage, we are looking forward the mechanisms behind that significant neuroanatomical damage that we saw.
The NADPH oxidase effect, that's an alcohol specific one, or no, or is that a generalized?
Because that is implicated in the alcohol metabolism.
Exactly, yeah, it's an alcohol specific, right?
I'm not
Okay.
sure, but I see it here, but I see your point. I mean, because that is,
Alcohol metabolism, right? Yeah, that's what I thought, but I could be wrong, but I thought it was more alcohol, which is partly why alcohol is
but
significantly.
here is similar. I mean,
Yes,
this
that's
part-
similar. Yeah.
because all of the drugs by activating T cell receptors of immune system, specifically TLR4, activates microglia toward becoming M1, which is pro-inflammatory. And interestingly, it was interesting for me. First, alcohol intake increased anti-inflammatory, but repeated.
Does that mean like first ever or like first, like early?
I mean, I should take that further, but I think we have that
This is why you have one glass of red wine a day. I'm just kidding.
J-shaped curve, but yeah,
first alcohol.
but we're dealing with people who are doing
but
repeated
also
high level use.
In
Yeah,
next steps, we can see that alcohol differentiately affects neurotransmitter pathways when you are taking it acutely versus chronically. It's interesting. It shifts from, for example, activation to deactivation, but how many times, I don't know exactly. So this was one pattern, increasing ROS, and directly also it can initiate apoptosis. So these are the neuroinflammation. Here, there is no trace of neurotransmitter imbalance, nothing like that. Pure inflammation phenomena behind neurotoxic effect. I said earlier that this immune system and changes in this immune system can affect neural transmission. So how those products, pro-inflammatory cytokines, can go and directly affect the receptors in our body. GABA, AMPA, and NMDA are for glutamate. So they can affect, by doing that, they will start affecting and doing neuroplasticity as well in the addiction.
So it blocks GABA receptor or turns off GABA, but it stimulates AMPA and NMDA.
As I
Is that right?
Specifically, in next slides, we will go through that. In acute phase, it is different from chronic phase.
Okay, so
Yes.
is this chronic or acute here?
Go to the next slide, Steve. That,
Just a moment, if.
Well, it's okay.
No,
oh, if you're gonna answer later, that's okay, we can
Yeah.
just defer it to later.
Yeah, you can answer it later. That's fine.
so, just. Now, the last thing that is, specific to alcohol is acetaldehyde toxicity itself. Which it builds in neurons and has its own toxic effect in the system. So
So are you guys familiar with acetaldehyde accumulation? Like what drug do we give? Right? Self, that's exactly what you're doing basically, yes.
Yep.
and another major factor is excitotoxicity, which is overstimulation of glutamate system, which the main factor here is increase in intracellular calcium, which has its downstream adverse effect, like again, oxidative. You see this interaction between different factors: oxidative stress, inflammation, and excitotoxicity. They interplay with each other and directly damaging mitochondrial dysfunction and affecting ATP production in the cell. So that will cause damage to the cell and finally activating apoptosis and cell death. Here, the effect of glutamate on glial cells and neurons are just very briefly, we are not going to into these details, but you see that glutamate by affecting, because when we take alcohol, the increase in production and release of glutamate, and also we will see the decrease in reuptake of glutamate in glial cells start to overactivate these receptors, NMDA, AMPA, and mGlut and iGlut, which eventually increase calcium. And we showed that calcium through different mechanisms cause neuronal death and damage. So now we finished those cellular and molecular parts. Besides that, every drug affects our neural pathways and neurotransmitter systems. And for alcohol, acute phase is totally different from chronic phase. So first, let's go to acute phase. Literally, it increases almost all systems, increase of opioid release, serotonin release, and reduction reuptake, dopamine release, glutamate release, and GABA release. But on glutamate, there is no effect, and inhibition of glutamatergic receptors. This is by overactivation of GABA and prevention of glutamate, that relaxation effect happens in acute phase. So that we can trace these changes in neurotransmitter pathways to behaviors that we see, like disinhibition, hypnotic activity, cognitive impairments, ataxia, and motor incoordination. it's related to that GABAergic inhibitory activity over activation of GABAergic, which is inhibitor. And because it activates a mesolimbic dopaminergic system, that system which starts from ventral tegmental area and its projections go to nucleus accumbens, and they call it reward secretory. That gives that good feeling, which keeps people taking drugs. And it also activates mu and kappa receptors, which in turn cause more activation in the dopaminergic neurons. That was the acute phase. But in chronic phase, here you see all the receptors were inhibited, but by here, upregulation, we have that upregulation of NMDA receptors. And this is very important because it manifests when people start withdrawal symptoms, overactivation of glutamate system. And also, we have reduction of opioid release and increased sensitivity. I was thinking every system is hungry. I mean, they are hungry because they had that over release. Now they will become sensitized, increased sensitivity and activity of, because the release in chronic phase, the release will go down. All the rest of, we can think about that NMDA receptors, opioid receptors, all are oversensitized. Again, because of the reduction in dopamine system, we have that supersensitization of D2. And reduction or no effect on GABA release, but down regulation of GABA. So in chronic phase, we lose that inhibitor system. So this was the changes that alcohol caused in our neurotransmitter systems. So getting closer to clinical aspect of neurotoxicity, these are the clinical syndromes that we have been familiar with, mainly Wernicke encephalopathy, which if it's not cured and treated, probably can lead to Korsakoff syndrome, hepatic encephalopathy, central pontomyelinosis. And here you see its prevalence among people who have alcohol use disorder.
I think the alcohol-related dementia, 3 to 24, it's a pretty big range.
Yeah, or the.
Yeah, that's probably
That is,
Yeah.
includes some of these other things, right?
Well, I
It's
think
not
yeah,
defined.
part of it is our terminology isn't fantastic around. I think you're probably gonna get to later, but yeah.
and all
Yeah.
Cerebellar, yeah, 0.4 to 42, that's
that
like,
is, I think, regarding the samples,
Yeah.
Participant by population, whether
Yeah.
you are looking for
Mhm.
in rehab centers or, for example, outpatient. I think that's because of a
fair,
little of it.
yeah.
So now, neuroimaging studies showed that mainly each one of those clinical syndromes affect which part of our brain. Then we can infer, okay, it makes sense. For example, in people with timing deficiency, we see this pattern that, for example, their cerebellum and mammillary bodies and hypothalamus, corpus callosum, and frontal is affected. And then the clinical picture and symptoms make sense. And it is very interesting. The inflammation affects forebrain and putamen, caudate, thalamus here, and hippocamp and amygdala. And it's very interesting. Liver disease, which is a combination of neuroinflammation and malnutrition, affects both of these patterns. And just quickly, I will go. almost all of us know that thiamine deficiency is a cause in Wernicke encephalopathy, and that's because it is a main factor in carbohydrates metabolism, and it will cause decrease in ATP and cause those oxidative stress we talked about earlier. Classically, I think we thought about Wernicke as these three clinical trials, but those are the percentage of patients with Wernicke encephalopathy that have exactly that symptom. And because of, underdiagnosis and misdiagnosis, now Kane criteria has been replaced in research and clinical care with relatively acceptable sensitivity and specificity. And if a patient has 2 out of 4 of these 4 symptoms, they are diagnosed by Wernicke encephalopathy. Dietary deficiency, oculomotor abnormalities, cerebral dysfunction, and altered mental states.
So yeah, low threshold to treat. So they've done autopsy data. We're finding there's actually a lot of damage that we weren't realizing.
Exactly.
So we
That
were
was
under treated.
exactly.
Yeah.
I did a lot of research, but I couldn't find, especially in US, we don't have any data about the prevalence of that data, which is
It's old,
for
yeah.
postmortem. Yeah, it's very old, and I don't know why nobody, because there are studies from Scandinavian
countries,
countries,
yeah.
but we didn't have that. And so treatment is easy, parenteral timing, but the problem is many of the patients will not be diagnosed.
Or they're going through withdrawals at home and having some of this happening, they're not actually in our care systems too, right? Some people have been having this damage repeatedly.
Exactly.
Mhm.
So these are the main areas affected, and if it goes untreated, around 80% of them develop Korsakoff syndrome, which is irreversible almost. And the core deficit will be amnesia, which is anterograde and retrograde, and other deficits in executive function, empathy, impaired visuospatial skills. To those who do you have any idea about visuospatial skills? Because it was also unfamiliar for myself. What exactly we say, because that is a part of it. I mean, cognitive impairment, even it's not very familiar for us, because in our training, we are not trained, okay, these are we are not, our trainings are not oriented to detect these kind. As you see, we have that criteria, but we don't have these details, nuances about cognitive impairments. And they can be dismissed and ignored in a patient easily because they are not severe enough to be diagnosed. So, for example, because it was interesting for myself, for example, reading a map, having a 3D understanding of your place. These things, but it is not seeing that criteria, you know? Or for example, specific, we have different memory types. Even I'm not familiar with that. So in clinic, I will reach to that point, without having that criteria and pathway for assessments, people will easily get missed. And we should know that these people cannot take care of themselves because they have cognitive impairments. So you see here a healthy brain. The cerebellar is okay, the ventricles are okay, and gyruses and so on. This is a patient with Korsakoff. But here, because this is from a study, they try to put emphasis on people in between. People they call subjects with uncomplicated alcoholism. They have brain damages, but they are not diagnosed by the criteria. So you see the damage started, and we have neuroimaging evidence for that. But this person is considered uncomplicated alcoholism based on the criteria, but they have neuroanatomical damage. And one important aspect is that at this stage, it can be reversible. Even those that are not because of thiamine deficiency. With rehabilitation, with appropriate care. And it's not a very short term. Some of them can be reversed for 2 or 3 years. But the point is, in this clinical care, they can be easily dismissed. So that was the point. I mean, we have those clinical syndromes with definitions and clinical criteria, but patients who have cognitive impairment but does not fall within that diagnosis, what are we going to do for them? But before going into that, just having another evidence. This is a study in Biobank, UK Biobank, which included around 30,000 patients. And they found that that negative impact of alcohol on brain is even by 1 or 2 drinks. And we cannot consider them as alcohol use disorder. Correct me. I mean, clinical side, I mean,
Agreed.
when I was reading.
Over what span of time?
Yeah, every day or,
Or 20 years or?
yeah,
I didn't go through that, but in these studies, Dr. Sheila, they will adjust for the year. I mean, you know, they will, for example, and also they have those big data they can compare with the same age. Do you remember that slide I showed, 63-year-old versus 63-year-old who have the disease? I mean, they have, because of having that big data, they can control for age and other.
I mean, this does match up with some of our own studies. There have been reports for quite some time in the US too about how even drinking 1 to 2 drinks a day, especially people who are older, affects their memory. Like,
yeah.
right? So,
And then they found, again, because they, I know it is a lot, I mean, 30,000 fMRI data is huge. They can do this further analysis, and they found that dose response relationship and also a global impact. So.
was there anything, just out of curiosity, about binge patterns versus more daily consumption, or did you see any comments about that? I'm curious.
I myself didn't see that, but I can check.
I'll go look into it, because I mean, because we've talked a lot about binge more recently
More
in the US.
damage, yeah.
That does do a lot more than we realize. So I'm just curious, but I'll look into it too. Thanks.
And also white matter damages, and yeah, that moderate alcohol consumption can worsen cognitive decline. And here, I think the best part of this presentation for myself was, I mean, getting known this this phenomena and terminology which was there since 2000. Yeah, and there are two. Let me see. Okay, there are 2 different theoretical approach. Some people will say, okay, we put those people who are not falling within any criteria or diagnosis and consider them in a continuum, uncomplicated alcoholism, or people who have cognitive impairments but are not diagnosed. And it's a continuum. They will go through this path if they continue drinking alcohol. But another theoretical approach is considering alcohol related brain damage as an umbrella term, which include, I think I cannot make it bigger now. All of these diagnoses from that's neurodegenerative syndrome to vascular events, because the person cannot walk safely, and then they have, because of taking alcohol, all of
Yeah,
them.
they have fall and they don't clot blood and they have a bleed in the brain and that contributes to the brain damage. As you have here, they have a TBI that because of their own.
Mhm.
So there's a lot of inputs. I agree.
Yes.
Yeah.
From
Mhm.
there to, for example, Wernicke encephalopathy and alcohol-related dementia. And I think, honestly, this was supported by Royal College psychiatrists, and they created a task force specifically for this and implemented programs across UK. I think this will help us to be cautious about the wide range of alcohol-related brain disease, and it will help to improve the clinical care better. But one point we should not dismiss is the moderators on this relationship between alcohol and neurotoxic neurodegeneration or neurotoxic effect of alcohol. For example, age is a factor, basic malnutrition, genetic predisposition, and also severity of alcohol use disorder. And these were supported by neuroimaging data as well. So another point, so again, why this is important? Because we don't want to miss people when there is a golden time we can reverse the track and we can help them. And again, we have both neuropsychological data and neuroimaging data that some of or most of those damages can be reversible if we intervene in time. But okay, here, just it was interesting for me retrospectively, yeah, so how things can be dismissed and ignored as totally different.
Yeah.
Mhm.
Here, now I want to move to practical clinical care experience and output of this presentation. I found this person is a psychiatrist. He started to focus on alcohol-related brain damage, especially in adolescents in UK. And in 2011, he wrote a letter about this challenge we have, that we are not providing appropriate care for people with this situation, and proposed some suggestions. Then he became in charge of a working group by Royal College of Physicians and to define alcohol-related brain damage, and also what should be done specifically in terms of clinical care, coordinated clinical care. And they provided very useful, actionable steps. Okay, we should, for example, that what was one was very simple but resonated with me. They said, okay, we should allocate a person who knows about the system to navigate and join them with this, because they cannot take care of their own, because they have that cognitive impairment. And here we are talking about NHS, and that's universal and healthcare. And
Do they recommend anything for detection of this kind of
that
earlier stage? Because I think maybe I'm up this,
Screening.
yeah, screening, because what I found, and this is maybe just be me, is sometimes patients will, if you do a quick talk to them or do a MOCA, they'll score higher than you'd expect, right? Compared to the memory deficit. I'm just wondering, is there any suggested screening tools in here?
this report was released in 2014.
Okay.
Then they were implementing those recommendations. Then they published an article in 2025, and they went to and asking healthcare workers, okay, what are the strengths, and they mentioned again, we don't have that screening tool.
Okay.
And there were, I don't know whether I bring it, because this I found found it very,
Yeah.
I mean,
Well, I see they mentioned the mocha here too, it just, and this is just my experience, but yeah, people do better on the mocha than you'd expect, given their memory is just, you start talking to them more and more.
but that was still a challenge. I mean,
Yeah.
and that having that trained staff to do that, and also
Yeah.
they are saying you should do that reassessment again and again,
Well,
because
fair.
maybe,
Yeah,
because next 3 months he will go down below the.
right. I think you need to follow them to really see that
Yeah.
a lot of times because it's subtle.
Yeah.
But
One-
they're deteriorating.
Very good resource that I want to even now, is it possible to go?
Yeah, you can share a new screen, it's fine, yeah, you wanna,
um,
if you wanna open up a website. But while he's doing that, any questions from anyone?
Yeah, this is really interesting. It's an area that I've been interested in. I think that um, I've always thought of it as kind of a continuum, and I see people who don't have all the criteria for, Wernicke's, but have some of them, and then have maybe some additional, ataxia or, some other area of the brain that may be affected. So, I mean, I think this term alcohol-related brain damage is a good one to just, and probably Wernicke's and Korsakoff's are probably too, too defined a criteria, I think that it can definitely be broader than that, and patients can have significant damage without having all of those clinical signs.
Yeah, my threshold to treat for Wernicke's is low. As
For sure.
you know, if you're concerned about someone's nutrition status and they're confused, just go ahead and do the time. Yeah.
And then, then to whom you will, for example, refer, I think one message was you should have that path for the patient ready. For example, okay, if I want to do memory assessment, I will refer them to, and then someone should navigate them, because
Yeah, they
Yeah.
won't follow through because you give an appointment and they don't form the memory.
Yeah.
Right, like they have it all written down,
And
they're never gonna make the appointment. Yeah.
they did a very good job. I mean, they recorded all of their, for example, recommendation, management through recovery. And I suggest it's 20 minutes, and they even, for example, the trajectory.
Let's put this link in the chat. How
Yeah,
about
yeah,
that?
sure.
Can you copy that?
Fully, I mean,
Then hit, there you go, perfect, thank you.
this was very helpful, I think. I mean, because they started from challenge, and then they proposed some measures, and then they implemented in different countries in UK, and now they are assessing their success. So I think, and still they are behind their expectation, like they didn't fulfill, but still they have something. I was thinking the next, I'm going to talk about Minnesota.
Sure.
Yeah.
That would be interesting.
There you go, the bottom, no, that's not that, the one above, you want the ethanol, that's
Yes.
your presentation. There you go.
Okay,
Share, there you go.
okay,
Perfect.
now, first let's a little advertise about my supervisor's previous work, because now I can even know more about the significance after doing this presentation myself. They started doing this in Liber from 10 years ago, and they produced these simple animated materials, and in each of them they will explain, okay, what will happen to the brain. For example, when you are taking medications, and when you are in recovery, and it's very interesting. The slides I showed you in the beginning of the presentation, I mean, addiction centers are eager to have these materials, because they say patients are asking, oh, what is happening to our mind? Or is there something wrong with our minds? Or is it reversible, irreversible? Or they are looking for the answers that they cannot find. So, this is one thing, and
These are done this in a bunch of different languages, right?
yeah, on the website, Library Body, there are 22 languages and again, these were developed by Hamid at three or four different levels. One is just 4 session and can help as a assessment, just for basic cognitive skills. And now we are talking with addiction centers because we are looking into implementing that and having the have some studies about their efficacy exactly in addiction recovery. And if a patient become interested, there are also further 16 sessions. And if, for example, I read about the chapters topic, for example, one is attention, what means memory. And first, for example, it explains what is memory, how it works, and then with some exercises, it helps the patients to improve. And they are designed to be done in group. So again, the addiction centers which we are communicating are very open to the idea. So you can find for your own institutes or practice if you think it's helpful. And
So full disclosure, I have to say, just remember disclosures when you're doing a talk,
oh
that you're involved with Dr. Ektiari,
yes,
who produces all these
Yes.
things. He is a researcher and new faculty at the University of Minnesota and with the medical discovery team on addiction. So we're not, the SAM is not saying automatically, we recommend this particular
I understand.
thing, but it's a good resource, I think, and there's not enough of this. Because we talk,
Right.
we need to have rehabilitation of people's brains when they're trying to go through recovery and trying to get more control of their life. So I think I'm
The
supportive of
point
the
that
idea.
I try to bring this because we are, we are inviting because now we are looking to, as I mentioned, within a community engagement
Mhm.
framework, we are
Yeah.
looking into redefining and improving the materials based on the needs here.
Exactly, which is
We are
wonderful.
talking,
Yeah.
I mean, with the help of NDTA and also we are negotiating with SLD to improve and fill that gap. I mean, we are saying, okay, people need cognitive rehabilitation, so what we are going to provide to them, and this is our.
Yes, oh yeah, and I like it, I'm just saying, we can't,
Yeah, but
Yeah.
I understand.
yeah.
So
Right.
Supports, I think, the American Dietetic Association recommendation of how many, what is considered to be non-hazardous drinking. So the 1 drink a day for women or 2 for men. I think that
Yes.
Hmm.
are
And I
Say
was,
that again, Sheila. You think it's what?
on par. I think that this supports the recommendation from the American Dietetic Association.
Oh,
This is
right.
just,
So just a small amount. I mean, and it
Yeah.
may be different for different ages and
right.
Yeah.
Absolutely.
the other thing is this isn't all, as you pointed out at the beginning, it's not all thiamine deficiency. I mean, that's just one part of it, right? Especially if we talk about the broader alcohol related brain damage, that there's other reasons, other things that are causing the damage. So that's the other question of how, besides for giving thiamine, what else can we do? Should we be giving something that reduces inflammation, that reduces reactive oxygen species,
Yep.
or
there are lots of, because they were at the, research level in animals, rats and mice. I didn't bring them because now
yeah.
each of these targets has become a potential, for example, for a research, for example, antioxidants, anti-inflammatory,
Mhm.
all of them. And you see, there are tons of molecules involved in each pathway and people are targeting them, but I thought that is a little,
If you're interested, Pam, so Ahmed Akhtiari has a strong interest in this, and he'll talk about it. We can have him come back for another journal club if we want. He's very excited.
Who's that? I'm sorry.
Ahmed Akhtiari.
Yeah, okay.
You know him?
No,
Okay, so he's one of these books that he was showing. He's
uh-huh,
a lab here doing research.
yeah,
Just had-
maybe that would.
He could come and talk about it more, I think, if we want to talk about that, because he's very interested in that concept about should we be doing more to treat, like, for people with methamphetamine use, right? Like,
Yeah,
to preventing neuronal damage in people who are using methamphetamine. There's talks about how to do that. I can invite him.
it would be, he might be an interesting speaker for the MinSam quarterly meeting.
Yeah, that's actually true. Yeah.
Mm-hmm.
Just,
Um,
I'm curious, I mean, because I found this
And we
data.
probably should wrap up too, because
We
it's
should, yeah.
it's 1 o'clock.
Okay.
Too.
oh, okay,
Speaking of MinSam, next week, next Wednesday evening is our next MinSam regional. meeting.
exactly, yeah. And we have people from the Minnesota Department of Health
Yep.
Drug Awareness Network coming. So I think that'll be interesting too. And they really are interested to connect with us about increasing their outreach.
Are you okay with sharing these slides or no?
Yeah.
You are? Okay. We'll put them up then. Any last?
Okay,
Just
where will they be?
wanted to mention
The
that
slides?
Minnesota has the highest binge drinking rates in the nation.
Doesn't surprise me.
Yeah.
Yeah.
And I was just saying, if we can implement something like that.
Here, yeah, and that's why it's, yes, I am, because it's a problem. The Wonder data set came out that the increase in alcohol-related mortality was the highest in the Midwest as well, too. Over the last
Mhm.
decades. So yeah, there's a problem locally. So, thank you. It's thought provoking.
Thank you very much. Very interesting.
Yeah, and he said he was happy to share the slides, Pam, so we can put them up.
Where would we put them up? Where would you put them up? On the website?
Yeah, on MinSam.
Okay,
He's up-
okay, yeah,
We can go through them first. So.
that'd be great. Thank you.
And you can remove some things. Yeah, yeah. So,
Yeah, sure.
thanks,
Okay,
everybody.
thank you.
We can
So
stop
you can
sharing.
shift into
Then we can,
AM here. There's super-
and we can also
I don't.
hit more. Oh, here it goes.
I don't
Let's
know
go.
what the topic
Let's stop recording.
is.
Yeah.
So now there's a national,